So this goes back to the first clinical application of mesenchymal stromal cells, which was done in 2004 on a single patient with steroid refractory graft versus host disease. And the reason to try that treatment was that mesenchymal stromal cells, in addition to their ability to form cartilage, bone, and adipose tissue, appear to have immune suppressive properties. At that time, it was found that they had the ability to suppress the proliferation of T cells. And so it was inferred from that they might be immune suppressive. And that was all that was known at the time the first patient was treated. And this patient was undergoing a haploidentical stem cell transplantation, did not respond to the standard treatment, which is steroids. And then there was no real treatment options. And so it was attempted in Stockholm at the Karolinska Institute to try these mesenchymal stromal cells, and it was a full response. So the case report was published in The Lancet, and it initiated other clinical trials that we did in a consortium. We did a phase 2 study in about 55 patients, again confirming that these cells are largely effective in a majority of patients. So we observed at that time, and this is now 2008, also published in The Lancet, that approximately 70% of all patients treated with mesenchymal stromal cells entered a remission. And it was also shown that patients in remission had a better survival than those who did not enter a remission. So that really started and boosted the field. I just indicated already the graft versus host disease as the first indication, but soon it became clear that other disorders that are associated with immune responses, allogeneic immune responses, or autoimmune responses would be potential indications for MSC treatment. So in the field of allotransplantation, not only graft versus host disease came up, but also organ transplantation. So we're thinking about kidney transplantation, for instance, to suppress chronic rejection. And currently there are several very promising studies ongoing to try to reduce immune suppression in patients after kidney transplantation by giving them stromal cells. And the great advantage would be that the lifelong treatment with immune suppression could be discontinued. It could be a temporary treatment, and a single treatment with MSCs could replace perhaps lifelong immune suppression. And that's not only very cost effective, but also important for patients, because the long-term use of these drugs is associated with fibrosis and ultimately with graft loss. So the potential of the treatment here is to prevent graft loss in the long term. In the field of autoimmunity, there are indications such as Crohn's disease, and in particular, Crohn's fistulas appear to be a very promising indication for the cells. And this is now about local injection versus systemic injection. So I would say in general it is immune suppression. Then there are other indications to form bone or cartilage, for instance in the case of osteoarthritis. And the idea initially was that these cells were able to form bone or cartilage, but there's some recent evidence suggesting that also these regenerative effects are indirectly mediated by the stromal cells, not because they form the bone, but they induce endogenous bone or cartilage formation. So, and in fact, it then ends up in immune modulation in the broader term. This is a complex question, and the practical challenges are, I would say, intimately related to the regulatory issues. And so for that I must explain first of all that stromal cells are considered a so-called ATMP, which is an advanced therapy medicinal product. So this is a special category of medicines that are separately regulated by the EMA, and this comprises cell therapy, tissue engineering, and gene therapy. And then also how you can bring these HCMPs to the clinic is either by a clinical trial, through market approval, or through a so-called hospital exemption, which means that you don't do the clinical trial, you have no market approval, but you are temporarily you temporarily avoid the market approval until in the end you must get the market approval as a single route. Now many of these innovations are coming from academic centers, and at a certain stage they have to turn into biotech companies in order to be able to get approval, market approval. So this interplay between academic research on the one hand and the biotech world at the other hand is still something that could be improved. And also because these HCMPs require, because they're drugs, they require a potency assay which explains how they work. And the idea is that you do the test before you administer the cells to the patient in order to know whether or not they will be effective. Now, if the working mechanism is not entirely clear, or there may be more than a single working mechanism, these potency assays are quite difficult, and they end up in being a consistency assay. But the regulatory issues surrounding this are quite considerable. Because all of this, there is a delay in the time frame between phase 1 clinical trial and market approval. And you see that regulatory systems around the world are trying to accelerate this process. For instance, in Japan, 2 new laws have been adopted to accelerate the process, mainly because of the iPS-derived products of Professor Yamanaka, but also in the US, and recently also the EMA in Europe has started a program to accelerate this whole process. But it's still in the, let's say, in the learning phase. At least the good part is that there is a notion that something needs to be done to get these products faster to patients. Yeah, if you come, research is clinical research and laboratory research. I would say in terms of clinical research, this year for the first time in Europe, the first MSC product is registered, and this is about an adipose tissue derived MSC product, and it is approved for the local treatment in patients with Crohn's fistulas. So this is the first time that an MSC product will now become available as a drug. In terms of the research and the underlying mechanisms for these cells, there are some new indications relating to the survival of the cells following injection into the patient. And it was known for some time already that these cells are not long-lived. They live maybe a couple of hours or maybe a couple of days, but not long-term. And there's now new evidence indicating that the apoptosis of the cells may be part of their mechanism, therapeutic mechanism. And this is done by elegant studies in mice, showing that there is an alloreactivity of the cells in the patients to the cells. Because of that, the cells will die, they will become apoptotic, they migrate to the lung, then they are phagocytosed by macrophages in the lung, and these are polarized to become immune suppressive. And that may be part of the mechanism. And that taps into something physiological, because during normal pregnancy there is placental trophoblast material that is shed into the circulation of the mother, goes to the lung, phagocytosed, polarizes macrophages. So this may be a mechanism through which the body regulates tissue homeostasis. And with the stromal cell therapy, we tap into this physiological mechanism.